Welcome to Maternal Infant Health Canada's educational seminar series. Maternal Infant Health Canada, MIHCAN for short, is comprised of doctors, researchers, traditional medicine practitioners, and healthcare workers from Canada, India, and around the world. Together, we aim to work closely with local healthcare workers, traditional medicine providers, governments, and community members to improve maternal and infant well-being and reduce preventable maternal and infant mortality in India and globally. Maternal Infant Health Canada recognizes that the only way to make a true lasting impact is to look at all the determinants of maternal and infant health. Our pillars include health and education, as well as clinical skills training, community economic development, innovations, and research and accountability. This webinar today, which is part of our first pillar, is on factors affecting the use of midwifery services in remote Nepal. And our speaker today is Kathy Ellis. Kathy Ellis is a senior instructor in the University of British Columbia's midwifery program. Kathy has worked in Uganda since 2005 and Nepal since 2007 with midwifery students as part of a global health course. She completed her PhD at the Simon Fraser University in Health Sciences and Global Health, focusing on access to midwifery care in remote areas of Nepal. She continues to work with nurses and midwives in urban and rural areas in Nepal and Uganda, and more recently, healthcare providers in the South Sudan. As with all of our public webinars, I must add the following disclaimer. There's a lot more that you can read, but generally, I need to say this course and handouts may contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. So for everybody watching today live, if you have questions during this webinar, please write them in the comment box at the bottom of the screen. You'll see when someone writes, it will flash, but if not, it just looks like a little bubble. So what we're going to do is we will capture these questions and then ask them at the end of the lecture. So please don't be shy about asking a question or asking for clarification. Sometimes if it is clarification, we may answer it during the lecture. If not, we will save everything. And at the end of the lecture, we'll go through all of the questions and Kathy can answer every inquiry you have. These webinars are about stimulating discussion on how we can all work together and support each other in our efforts to improve maternal and infant health. So we do want to hear from you. So without further ado, I am going to let Kathy take it away. So thank you so much.
So thank you very much for inviting me tonight. I'll just start by talking about what I perceived as the problem when I started my research in Nepal in around 2014. So the maternal mortality ratio was still quite high, although it had been reduced from around 901 per 100,000 live births, still at 258, it was quite high for the region. Bangladesh had been able to reduce to 176, Sri Lanka to 75 actually. So Nepal still had quite a problem, and most of the mothers who were dying, it was actually related to hemorrhage, and that is the same as maternal mortality worldwide, no different. Nepal also has a somewhat high perinatal mortality rate. It's notable that in the rural area, it's quite a bit higher than in the urban area, therefore the need to work with rural and remote areas more. So in my research area, which I will show you on a map and explain to you a little bit more in a couple of minutes, only 30% of mothers actually used skilled birth attendants. So skilled birth attendants would be doctor, nurse, or midwife attending the birth and did not include traditional birth attendants. Some authors assert that 83% of maternal deaths could be eliminated if skilled attendants were helping the mother. So Nepal actually has very good government policies relating to childbirth. They had decided through a large document in 2006 to train skilled birth attendants and set up rural birthing centers. The most common skilled birth attendant for the rural and remote areas was actually the auxiliary nurse midwife, with a basic 18 months of training and then an additional 2 months in skilled birth attendance. They also have a really good community system of female community health volunteers and mothers groups. And those female community health volunteers have an education role, as well as a role in distributing some basic medications, such as vitamin A for young children, oral rehydration salts, and other things. So the policy of female community health volunteer relates to childbirth in that they, with the mothers groups, actually talk to pregnant women in the communities about birth planning preparedness, best practices for childbirth, what they could do during the pregnancy to improve their health, and so on. The government also, through a program called the AMA program, provided financial incentive payments for mothers, also a small amount for the healthcare workers and to the facilities. I did find out through the course of my research that the financial incentive given to mothers in the in the remote areas, in the mountainous areas, was not nearly enough. And I have seen through government documents that they have increased the amount given to mothers. And that incentive was given to mothers upon their delivery at the healthcare facility. They were not given to mothers beforehand, and they were not given for mothers delivering at home. So lately, universities have begun to educate professional midwives, and there's several programs going on. This year, the first batch have graduated in Nepal, and I expect I will meet them when I go there later on this month. But I will particularly be working with a remote Academy of Health Sciences who are going to train midwives, I believe, through a 3-year program. So all around Nepal, facility-based births are promoted. The government wants everybody to be attended by skilled birth attendants, and all the rural birthing centers that they have set up have at least one skilled birth attendant. I conducted my research in a small area of Solukhumbu, and I'll show you a map in just a moment, in the district hospital, 2 primary health centers, and 3 birthing centers. So my research objectives were to assess mothers and families' attitudes and practices around birth and how that affected families' willingness to use skilled birth attendants in facilities, to assess the readiness of one remote area of Nepal's rural health system to provide services to parturient women, and to see what the links were between mothers' perceptions around birth and their use of the healthcare system. So here's the map I'm talking about of Nepal, and Solukhumbu is an area in the northeastern part of Nepal, and this map points to its administrative capital, which is Salari, and Paplu, another town which is contiguous with Salari. Paplu has the district hospital, and I worked in the other primary health centers and birthing centers in that area. At the time of my research, there were no roads extending from one side to the other, only about 1 hour from Paplu over a bumpy track. So I'm showing you this picture just to give you an idea what this is like. And communities living in these areas without roads really find it quite difficult to get to these birthing centers that the government wants them to birth in. So when I was working in one of the primary health centers, doing my research, observing two births during the night with the skilled birth attendants and the families, I realized that one woman was carried from the other side of this mountain. So I said to the director of the health center, I said, one of the mothers who delivered in the night was carried all the way from the other side of that mountain. He said, no, they weren't. I said, yes, they were carried from the other side of that mountain. And he said, no, the other side of that hill. So you can see that what our idea of what a remote place is and their idea may be not quite the same. This picture I'm showing you can frame my research because it's a picture of a grandmother and her great-granddaughter. And this grandmother lost her daughter in childbirth about 45 years ago. Her daughter died at home while trying to deliver. There was no birth attendant, no road, no phone, nowhere to get her to help. But the unfortunate thing is that this situation is still quite similar for people in these remote villages and communities today. While I was collecting my data over a 4-month period, 3 mothers died in these remote communities during childbirth. This particular picture is of the baby they named Remember and her little sister taking care of her. And we went to her home not to interview them or collect data, but so that Bimala, my co-researcher and translator, who was working with me, would help them and teach them how to bottle feed the baby so that the baby would have a chance of survival. And so we did that, and this baby, with a little help, did survive. I'm now going to show you just 2 slides from my literature review. The first one is, what are the barriers to the use of a skilled birth attendant worldwide? So distance and cost were cited in most but not all of Nepalese studies. Most studies showed a skilled human resource shortage, and I think we would have that same problem in rural and remote Canada. They talked about the role of community-based cadres, such as the female community birth attendants and other community-based caregivers. Factors such as social support, a woman's ability to act on their own will, the autonomy, their beliefs about birth, their customs were also prevalent in the literature, and the idea about respectful and skilled care lacking in healthcare facilities being a barrier was also found. This next slide is about quality of care. So generally in the literature, a high maternal mortality despite the attendance by skilled birth attendants points to a quality gap. So this might mean a rural or remote healthcare center where there are few births, and so the person does not have an opportunity to practice their midwifery skills very often, or the training and updates are not regular. Enabling factors need to be present in order for the skilled birth attendant to do their job. That would include electricity, water, phones, supplies, equipment, medication, etc. Perceived quality of care affected facility use as community members relate to each other their stories of birthing at a particular facility. Over-medicalization continues to be a big problem in many facilities, and mothers and families fear to go to the facility because they do not want medical interventions that they consider to be unnecessary, unhealthy, and unwanted. The WHO in its 2018, one of its 2018 documents is now urging all skilled birth attendants to be able to facilitate physiological birth and to be able to work with women in a cultural way that is familiar and comfortable to them. So to have the skills to save a life is no longer by WHO considered enough. So my research questions: what are the factors that women report that affect their use of skilled birth attendants in remote Nepal? What are the barriers and facilitators to establishing skilled care at birth in these settings? And what are the gaps in skill sets and in enabling factors in the healthcare facilities to provide both culturally safe and skilled birth attendants? So I'm going to tell you very briefly about two different approaches that I used to develop my research questions. I looked at Jordan from 1993, Childbirth and Authoritative Knowledge. It's a very useful framework which describes the fact that for any domain there is more than one knowledge system. In terms of childbirth, the medical system is so much more powerful, and that's the system that people listen to because it is the one that counts. This framework is useful to investigate the decisions that people make and the decisions that government also makes about home birthing and facility-based birthing. It's important to consider the effects of exporting a medical model for birthing from Western countries to other countries and see the effects that it has. And this framework is also useful for that. Then many of you are probably familiar with the 3 delays framework. It categorizes the causes of maternal mortality within the 3 levels: decision-making at home, both knowing that there is understanding that there might be a problem, and basically having the autonomy to make that decision to move to a facility where life-saving help may be available. The second one, just the delay in getting there. And with that picture of the mountains, we saw how difficult it might be to get there once the decision is made. And then the third one, the delay in obtaining the care once people are there. So there are some weaknesses with the 3 delays model, and one of them is that it does not describe the community level influences that have to do with mothers arriving at a healthcare facility. So my research design is a concurrent mixed methods design. And a concurrent embedded design is meaning that I'm doing all my methods during the same time frame, and I embedded the surveys within the main method, which are my interviews. So I did participant and site observation, daily field notes. I did 67 interviews, and I will show you in a moment with whom I conducted the interviews. We did 6 healthcare facility surveys, and those were the facilities that were chosen with our input, but were chosen by the health system that had enough cases of childbirth in the facility that we could really study there. And then it might not sound like very many, but we did 12 nurse skills surveys, but there only were about 13 nurses who had been trained in skilled birth attendance in the facilities where our research took place. So the first survey is a WHO service availability and readiness survey. So we conducted that with the managers of the 6 facilities. We found the skilled birth attendant was not always available. Basic equipment and supplies were usually present, and that's a really positive thing because they could attend the normal birth with the basic equipment and supplies. However, they lacked adequate supplies to manage obstetrical shock, which would result from postpartum hemorrhage. Life-saving procedures and referral protocols were not always available, and mothers did not have choices. So I added questions about respectful care to this survey and found that mothers were given very few choices in childbirth when they could have been given them. So the second one is a skilled birth assessment survey. It was comprised of knowledge and skill tests, and we found that knowledge was higher than skills except for nurses who worked in the district hospital. However, only a third of all the people who we assessed scored as very competent in most essential skills. And very competent meant more than 85% because that was the same way that the assessment was used in other places in Nepal. So we also used 85% as very competent. But if you were not 85% competent in attending a hemorrhage, you would wonder whether that SBA working alone would be able to save a life. So the median score for shock due to postpartum hemorrhage was 77.4 out of 100 for recently trained, compared to those trained 4 or more years ago where it was only 67, indicating a need for ongoing refresher courses and updates. But the minimum shock scores were very low, 45 to 65%. So one would assume that they might not be able to save a life when a woman had hemorrhage. So I wanted to show you this little chart of the interviews I did using stratified purpose of sampling. I did know that I wanted to interview mothers having home births, hospital births, and who had both home and hospitals births, and those who had to transfer to facility. So I searched these mothers out through the female community health volunteers. So that's how I found the women, and here is the number of those mothers that I interviewed. I also interviewed maternity staff, which are the nurses and auxiliary nurse midwives, and the doctors, ones who were actively working with maternity care, only 17 altogether. And yeah, they're combined. There were only 3 doctors. The rest were auxiliary nurse midwives and a couple of nurses. 14 female community birth volunteers, and that is throughout both central, eastern, and western Solukhumbu. Key informants, I interviewed 5. 2 were ex-combatants from the war in Nepal who had worked in very remote places, who had a very good knowledge of women's healthcare needs throughout remote areas of Nepal. And 2 others were older women in a community who had delivered a couple of decades ago, and we wanted to find out about their cultural norms. I also, partway through the interviews, decided that because women were talking so much about the use of shaman as alternate healthcare workers, we needed to interview them. So we did interview 6 of them. I now wanted to talk about the importance of local knowledge and the team of interviewers. And this picture is Bimala, who is currently a participant in this webinar with her baby Nina and one of her babysitters. And there are our tents in one of the villages where we stayed for a number of days to interview mothers, community health volunteers, healthcare workers, and also do the survey at the local health facility. So Bimala, being from one of the ethnic groups that was most prevalent in this area and could relate so much to the women because of her baby Nina being with her and having had her experience of having a baby so recently, was so important to the success of the interviewing, particularly with the remote mothers. So I can't explain really anymore how important it was to be working with people who had a knowledge of both the culture and rural areas. This is one of the experts. This is Rashmi on the left, that's me on the right, who is an expert midwife known throughout Nepal, who is known throughout Nepal and who was the head nurse of Patan Hospital, one of the most well-known hospitals. So when she came to do the assessment of the auxiliary nurse midwife SBAs, she was very well accepted. Also, her way of being in the rural area and her experience in working all through Nepal since the early 80s when they set up when the government had programs in safe motherhood was very important. I don't think it would have been as good an assessment if we would have had younger, even master's trained midwives. I think the choice was very good. And lastly, I'll introduce through this slide Pema's sister, Pema Sherpa, who was actually the first trained midwife in Solukhumbu, who attended all the births, who came to the district hospital, all the people who had problems. Then she was the head nurse there, and then she was the teacher at the institute there for training auxiliary nurse midwives. And later on, she became the nurse who went with a porter carrying a portable ultrasound to attract remote women to come to an antenatal visit in many villages. So her participation in both interviewing and assessing the nurses was so important. I will now just briefly tell you about the interview data analysis. I used an a priori and inductive approach, meaning I used some of the themes from prior research to consider as I did my interviews, and then I added all new information. I used a code book and thematic analysis to analyze my interviews, of which there were 67. Then I entered them in vivo and I coded them. And I did do member checks to see about validity, and I used inter-rater. I passed several of my interviews to another research to see whether another researcher would have coded them the same. So I tried to make sure that my analysis was correct. So the next couple of slides talk about my findings. So these findings were regarding birthing at home, and these were interviews with the mothers and female health volunteers. So they all told us that birthing at home was customary. They did plan for birth, but not the way we plan for something going wrong. They planned for it to be normal. For their first pregnancy, women had very little knowledge of what was going to happen. They did value traditional birthing procedures, some of the most important of those being hot oil massages, the drinking of hot drinks, particularly soup, positions, and moving around as desired for both the labor and the birth. They did use the services of the shaman as a parallel system. Shaman did not prevent women from going to the hospital. Some women took their shaman with them, and only certain sites allowed that. Some of the SBAs chased them away, and that made the women very upset. However, we can't romanticize the practices at home because some were evidence-based and some were very unsafe. The particular unsafe ones having to do with tying the placenta onto a hoe if they had delayed placental delivery, or birthing the babies onto a cold surface and not drying and wrapping the baby until the placenta came out. So I wanted to just share a few of the findings about facility birthing with you. They all thought that facility births saved lives. Families made decisions, not just the women herself, but the family. Barriers included lack of carriers to carry the women to the facility and the cost. Women were very upset about painful, out-of-date practices such as episiotomy, and being made naked was very upsetting to them. And I think by that they meant having to put on gowns and being exposed, because they were certainly not totally naked to deliver. But they were very upset with that, and not having choice and things done to them without their consent. They felt very ashamed if their bodies were exposed, and they were extremely shy. Maternity care workers also thought that facility birth saved lives, but they thought the families lacked awareness and the birth knowledge. They thought if they only had awareness, they would go to the facility. They didn't realize that the community were resisting the procedures of the hospital. They all agreed there was a shortage of skilled staff, supplies, and medication. And in fact, there was only one physician who had the training to provide a cesarean section in the district hospital. And when he wasn't present, when he had to be away for any reason, there was nobody in the whole district who could do a cesarean. Interesting point that one of them brought up, they lose their complex skills. They're trained for a lot more than just doing a cesarean section, but working in a remote area, they don't have the opportunity, and therefore they lose their skills. Few nurses actually acknowledge the harsh treatment of the nurses towards the mothers, which both community members and mothers spoke of. This is a picture of one of the remote site delivery rooms. It might not look very good to you, but in fact, this was one of the better facilities. The caregivers were actually quite good. We visit this facility every year. We don't, of course, nobody really likes this delivery table. It was carried for 3 days from the nearest road when it was brought there, as was the lamp, the refrigerator in the clinic, and everything else. So they're doing the best they can in a remote area. I think if they were able to meet some of the desires of the local women, such as not being required to lie down and be exposed during the delivery, if they could somehow manage to let them have a delivery position of choice and avoid the episiotomy, that women would be a lot happier to come to this facility. So I'm just getting to the end of my talk now. So a couple of highlights and conclusions from my research were that it did contribute to theory. It affirms both of the theoretical frameworks that I used during my research. And it showed us that we do need to address barriers around skilled birth attendant attitudes and practices. It is not enough to train people in skilled birth attendants, whether they're nurses, midwives, or doctors, if their attitudes and practices are not relatable to the community or acceptable by the community, then people won't want to go to them except when they think they're dying. So I think that my research did bring about some new knowledge, mixed methods. I found a way to access and establish skilled, culturally acceptable care in remote Nepalese birth facilities. So women would access care more if the care was changed a little bit, and skilled birth attendants would be improved if the enabling factors were strengthened in each of these facilities. So recommendations: mothers and remote communities can assist in matching facility practices with their own needs and preferences. Maternity staff really need frequent updates, not only for managing emergencies, but also updates including respectful birth. Financial incentives are very important because families found it a big financial burden to have to pay people to get, they didn't have to pay the people to carry them, but they had to pay for food and lodging of those carriers once they got to the facility. Now, my last idea would be, can we use these methods to assess health system and community birthing needs in rural areas of India or elsewhere? So I think I have come up with a system or a mixed method, some mixed methods that can be used in any country who has these kind of similar problems, which would be higher than acceptable maternal and neonatal mortality, skilled birth attendants who do not find it easy to have updates and refresher courses, therefore their skills might not be adequate. And by the way, I forgot to mention that when we assess the skills of the nurses, we followed it with a half day to a day of gap training so that the skills they did not get were actually refreshed the day after their assessment. So that could be also a very good method to use in rural or remote areas where caregivers do not actually attend many births, so therefore they don't have many emergencies, therefore their skills might be getting a bit rusty. And then the other survey, the WHO survey, which is currently being used in other countries as well, such as South Sudan, actually gives at least a momentary idea of what equipment and supplies are currently ready and available for use in the facility. So I think by looking at both the health system and the personal stories of the women about their birth and the ideas from the community members, other geographical areas, governments, NGOs, and communities can improve the health of their communities and birthing mothers. Thank you.
Thank you, Kathy. That was really wonderful and very informative. We are gathering some questions down at the bottom. So what I'm going to do now is I'll just start asking some of the questions. And for everybody who's watching, if you have any other questions that you would like to ask, feel free to continue to write things in the chat box, and we'll just continue until there are either no more questions or until we're done the hour. So we're going to start off with the first question, which is, when you were talking about the few shamans that you interviewed, I was just curious to know if they were also acting, and I think you sort of touched on this, if they were also acting as the primary birth attendants, or if mostly the shamans were just additional maternal support.
Yeah. No, they did not attend the birth. I found it interesting, though, that in certain communities where there was no nurse, no midwife, no medically trained person at all, they were able to diagnose labor just by being with the woman, asking about her symptoms and observing her. And they could tell whether she was in labor or not. So usually they were a parallel system, and their main job was to remove problems from the spiritual sphere that women might be having, which might cause a problem during their birthing. And I was able to see shamans at work twice, once during my research and once during my work with students, where a woman's birth was delayed in the facility. And so she asked us that a shaman be brought in, so that he came. Most of them were men. We interviewed one woman shaman, and he came in, and I said, sure, I like shaman, come in. So I watched him do his chanting and his ceremony, and then labor started up pretty soon after that, and she did deliver that night. So,
Okay, very neat.
yeah.
Yeah, can you talk a bit more about the local knowledge of pregnancy and childbirth? Do the people in the communities where you work practice traditional medicine, or is it mostly allopathic forms?
So we didn't find too many herbal medicine practitioners, but we found that there was common community cures for things that they all knew. Like everybody knew what to do. Everybody knew what kind of soup. For example, I interviewed a postpartum mother with Bimala, with my translator, in a tea house. And we always offer to get them some food or snack when we're interviewing them. I said, can I get you some food? She said, yes. I said, what would you like? She said, soup. I said, what kind? She said, the woman will know. Like the woman, she knew she was postpartum. Everybody knows that soup with fenugreek in it is what you give a postpartum woman. Everybody knows that. So, and with egg in it. Like everybody knows what they're supposed to take both during labor and in postpartum.
Yeah. I know that's very common in Chinese medicine as well, where there is a specific postpartum soup that is given, and the moms know, and they pass it down to, so moms and aunts, someone's going to make that soup for you. So very interesting. So Farah had a question where she was wondering, why are there so few specialists in the remote area? Having only one physician who can do a C-section sounds really difficult.
Nobody wants to work there.
Yeah.
Nobody will stay there. The government pays very little for physicians to work in government hospitals. They have to have their private practice on the side. In these areas, nobody can afford to pay a private physician. This is an area where people are really quite poor. So nobody wants to stay in the rural area. This particular physician was hired by a very well-known NGO and paid extra so he would stay there. The other problem happens that when they have a family, there's no schools appropriate for their children, because like they've spent a lot of time and energy getting educated. They want their children to go to a different kind of school than a village school. So doctors do not like to work in rural areas, especially remote.
Yeah, which makes absolute sense.
Yeah.
Which actually leads into the next question. So the geography and low population density in this part of Nepal seems to make it difficult for caregivers to keep up their clinical skills. What suggestions, you did touch on this a bit, but what suggestions do you have to get around these problems?
So I think that they should, first of all, they should try to figure out how to get more than one doctor. And when I go back this year, I may find there is more than one. But if a doctor could rotate between the rural area and the urban area, spending a month each year doing the more complex procedures and things like that, then they probably would feel much better. The auxiliary nurse midwives who were in training in that area did go to busy hospitals to get extra training. It's definitely possible. So it's not the doctor would need more training, but to do some practice in a busy urban hospital would be possible.
Could you maybe touch and talk a bit more about the abusive practices in the birthing centers? It sounds like a huge problem.
Yeah, so this is not different than in any other country in the world, actually. But the thing is that the caregivers don't seem to be aware of what constitutes abuse, and there is no oversight. So unconsented procedures like episiotomy, even if they say no, they still do it. If they don't want to get sutured, they suture them anyway. They make them do it. They make them go into lithotomy position when they don't want to. They make them lie down sometimes during labor and not move around. And it's not like they have an epidural or anything like that. Like, this is basic childbirth. Like, they could be operating like a more modern birth center, like position of your choice, ropes hanging from the ceiling, deliver on mats, like, who's to know? Nobody would know, but yet they're on those delivery tables. So, and then being treated harshly. So some mothers who had many children felt so much shame. They were even just afraid to even go to vaccinate their children because they thought they would be yelled at for having too many kids. So the nurse is often seen as a figure of authority to keep the people in line. They must birth in the facility. They must use family planning. They must go to antenatal care 4 times. So yeah, that's the main abuse, I would say.
That makes a lot of sense, and you do see that in a lot of places around the world. Now, I know this wasn't part of your research, but on that same, when you're seeing these abuses happening, and were there, maybe not part of your research, but discussions about like, how open did you find the medical staff to discussions about informed consent and about the new data on unnecessary over-medicalized practices? Like, is there any, because obviously there's a lot written in the WHO. We have the research to show why you wouldn't do that. So I'm just curious that if they have any openness to maybe changing those practices.
So at the end of my data collection, I did go to each caregiver that I could get to. Some of them I couldn't get to because they had come to us. So if they lived too far away, I couldn't go there.
Yep.
But the ones that we were able to, we talked to them about the results, and some of them did agree that women were treated harshly and that was a barrier to care. Others did not believe it at all and thought that they were right and the communities and women were wrong. But since we've been back 2 times to those communities since I did my research, I found that when I'm working with them, and I am licensed in Nepal, when I'm working with them, they're okay not to do an episiotomy, and they're a little bit more gentle, and they stop the real lithotomy and get them semi-sitting on that table we looked at. So I think they need side-by-side help to change some of the procedures. It's not easy.
Mm-hmm. Yeah. Now, on that same note, about talking about, changing views, you had talked about the shamans and some of the inappropriate practices that we're doing, like suggesting the baby be birthed onto a cold floor. Did you find that there was any openness with the shamans to hearing about safe birth practices, or was that also not? So
we haven't started that program yet with the shamans. Okay. they were very happy to talk to us. Nobody did not want to talk to us, but we basically asked them about being a shaman and their role with childbearing women. So it became very clear that their role was in a totally different sphere. It didn't have to do with the actual childbirth itself. However, they have already been to, there has been a DAMI training. DAMI is the name for shaman. There's been a DAMI training to train them on emergencies at childbirth or danger signs, so that they would know that that wasn't evil spirits, that bleeding in pregnancy is a bad thing. Most of them would know that, but some of them might not. But now every time you turn around, there's more of them. So the head of one of these remote health centers wants us to do some more training when we go this year to bring the new ones up to date with what are some of these danger signs in pregnancy. But usually they say, oh, yes, I just removed these evil spirits from the woman, and then she can go and deliver well, and she should go to the health facility. Like, if she wants to. Like, most of them don't think one way or the other, but if they do, they never seem to be against the health facility. They don't interfere with the medical work.
Okay.
Yeah.
Oh, that's great. Because you don't always see that in other regions, so that's interesting to hear. The next question is, did the field workers assess pregnant women for high-risk pregnancies and educate them to consider institutional deliveries? This could control for planning expectations of normal birth.
So by field workers, I think that question might mean female community volunteers, health volunteers. So basically the female community health volunteers they register all the pregnant women in their ward, which is a community of, I think, 80 houses, 80 families, small group. And then they try to find out who the pregnant women are, visit them, and get them to go to antenatal care in the health facility. So those nurses in the health facility are supposed to be the ones who find out who is at higher risk. But basically, the nurses tell everybody to deliver in the facility. But if they're higher risk, they probably say, please come and stay in town, come and stay with a relative or friend a few weeks before. Okay. I think they do that pretty well. We've seen people get also leaving the area and going to Kathmandu if they were very risky.
Okay.
Yeah.
Another question is, what are the SBA's views about refresher training programs?
They love it when we go there and do it. And what we've started to do is coaching. So we'll go and sit down with them and we'll just say, how is it going? What have been some of the more complex cases? What would you like us to review? We give them a list of a few things to make it easier, and then they usually say PPH, so then we'll do a presentation on that. When it's usually doctors and midwives together. If we're
so postpartum hemorrhage.
Yeah, postpartum hemorrhage. And if there are any doctors in the facility where we are, we could be presenting that together with them and with Dr. Mickey, who goes with our student program as well, so kind of interprofessional. And then sometimes quietly after, the auxiliary nurse midwives will say to me, can you review shoulder dystocia with us, because we had one. Like, sometimes it's in public, like they can say to everybody what they want to do, and sometimes it's kind of quietly after.
Yeah, as a kind of not a pride, but they want to still maintain their sense of that they're knowledgeable and skilled, and so by admitting that they need some extra help, sometimes maybe there's a...
But they're also shy, right?
Oh, okay, okay. There's also a shyness, okay.
Yeah, like we're getting to know them, but a lot of the people do move around a lot in the remote area. As soon as, and they're all female, the auxiliary nurse midwives, and they can move back to their own communities, they do so because then they'll want to get married with a local person. They'll want, that's usually what they do. So people move around a lot.
Our next question is, thank you, Kathy, for a brilliant presentation. I know it will be difficult for you to generalize, but are you able to comment on the competency of the traditional birth attendants who care for the women in the remote areas?
So we searched and searched to meet traditional birth attendants, and we talked with people who knew, and we only ever heard of one in the whole area. You know why? Because they had de-skilled them. They had de-skilled them and discontinued training or any support for them more than 20 years ago. And because these ladies were older, they're just not working anymore. So the one who was there, we were not able to meet with her. She lived quite remotely and she couldn't come and we couldn't go to her place due to slippery walking conditions from the long rainy season. But the only thing that when anybody ever mentioned that, they said she comes for cases of retained placenta.
Okay.
However, having said that, we did work with traditional birth attendants in other parts of Nepal who I thought were actually quite good and very supportive to their communities. And they brought in all the cases of uterine prolapse, which is the biggest problem for women in Nepal. They would accompany them in, bring them in so that the women could be seen at a clinic and get a referral for surgery in Kathmandu. But we used to teach them starting at around 2007, 2008, 2009, 10, but other areas. So this particular area of Solukhumbu, I don't think we could have been lied to all over the place because we had, good responses for almost everything. Yeah.
Can you speak about the training received by midwives and on-site mentoring support provided to them? I'm not sure if that...
So the auxiliary nurse midwives got 18 months of training. Some of them got 24 months if they were taught by Pema's sister, whose picture we saw, and was the first nurse midwife to train auxiliary nurse midwives for remote mountainous areas. But when they get sent out then to do their duty in one of these remote birthing centers, they rarely get any support. And that's why our particular program at University of British Columbia, we work in remote areas of Nepal, other areas like, if anybody recognizes the names of Mugu and Jumla, they're extremely remote areas. And we teach auxiliary nurse midwives who haven't had refreshers for years. And some of them walk for days to come to the workshop. Mm-hmm. So we do the best we can considering we're only there for short times.
Okay. So we've got 3 more questions and then we'll wrap it up there just because I know we're kind of reaching our time limit. So hopefully people can stay on just for the last little bit as we wrap up. But another question is, if discussed, how open did you find the medical... Oh, wait. I think we already talked about that one. That's okay. Could you talk a bit more about the social determinants of maternal health in this part of Nepal? Poverty, social status, etc.?
Okay, so we chose this part for work and research because it's an underdeveloped area, a food insecure area compared to the, I would say, more beautiful part of Solukhumbu where you can go for trekking and where you can see Mount Everest. We never saw it. We rarely see snow-capped mountains because we're in those lower hilly areas. Occasionally you can see them and then it's really great, but never Mount Everest. So these areas are lower areas. The biggest thing about it that I found surprising when I first started to go there and to work there is, and I also found this out through research, but also firsthand, at least a third of the male members of the household, like the husbands, are gone at any time of the year to work outside of the country. Like, that's a huge number. And many, many households are maintained by women. And then they get money sent from Korea, Malaysia, Dubai, Qatar, anywhere like that. So it's quite difficult for the people. They absolutely cannot live by the money they make by growing food. And some households, there's only one person who's a fit adult to actually do the farming, because there's a lot of old people who do some work around the farm, of course, to the best of their ability, and then just small children who go to school. Husbands are away. Yeah.
Yeah. Two more things. Number one, can you share a copy of your thesis with us?
Yes, I can definitely give you the link. That would be lovely.
All right. And did you do a cost breakdown of what implementing kind of further training for skilled attendants would be, or is there any other when it comes, just when it comes to cost for implementation of further training?
No, but I think the regular updates for midwives is not such an expensive thing to do. It's more having the political will and saying, yes, these people need regular updates. Other than our small team and the work that we did and we continue to do, the medical health officer does one day workshop a year.
Okay.
People are supposed to come for that, and that's good. I mean, they try, but again, the distances are really long to travel. People cannot be away from their post very long, and I don't think they have planned a budget to go and actually train people where they are in their workplaces.
Mm-hmm. And I think our final question is actually going to be a comment by Bimala. Did I say it correctly? Yeah.
Yeah.
Very well put, concise and clear presentation explaining all important findings on the research, Kathy. I just wanted to share a bit of information on obstetric abuse. A student now, a graduate, informed me that one of the main model hospitals for maternity care providing skilled birth attendance course still teach students to perform episiotomies on all patients. She did not have a single patient on whom she did not perform a episiotomy because her mentor asked her to do so. So the question is, what can we do about that?
Well, we can do something about it. We are continuing to work with them. We're going to join forces with UNFPA, who is providing a lot of support for the new midwifery training programs. When people get out of the new midwifery training programs, I do not think that they will be trained to do episiotomy on everybody. I think it's the old skilled birth attendant programs, and I think we just have to keep working with them and possibly try to have some influence at the national level. And I think so far our team has only had one influence on the national level, and that was for the implementation of delayed cord clamping for the newborn. So they're now trying to do that, whereas before they didn't know about it.
Okay. And another comment she had was that some new information that a new cadre of professional midwives with 3-year midwifery course just graduated in 2019. So Bimla has high hopes that as more professional midwives increase in Nepal, most of the problems we have encountered during Kathy's research will be resolved. And so that's great news and very exciting. We'll have to keep an eye out, and you'll have to keep us informed to see how that changes and progresses. And then can you please confirm the years of your study? That was then I think that
I have been working in Nepal since I got invited in November 2006. So we started working there 2007. Once a year, we went usually to rural and remote areas. I collected this. I first went to all my research sites 2014. just to observe. I started collecting data all during the fall of 2016. And then I defended my thesis last year, which 2019.
Congratulations. Wow. Troy in India says, thank you, Kathy, for the excellent presentation. The situation is very similar in parts of India. Your study has given us great insights, and we're currently designing a midwifery effectiveness study with local government.
Excellent.
So I think that would be great to hear from you, Troy, and to hear if you have questions, or just to get that communication going, because this is really great work and we are very supportive of the work you guys are doing in India. So keep it up.
Let's keep in touch.
Yes, yeah, it's great. And then finally, the last comment of the evening, because it is now almost 9:10, and I'm not sure, 10 o'clock in India. Physicians, this is by Mickey, physicians often teach nurses outdated ideas in training. Old school ideas are the most difficult to dislodge, and that is very true. But we are all here to change that, and hopefully, hopefully all of us working together will be able to make the profound impact that we want to do to help the mothers and these infants. So yes, thank you everybody for tuning in. Thank you so much, Kathy. That was wonderful and inspiring and informative. So thank you everybody tuning in from all over the world. We really appreciate these lectures, and we appreciate your input and all of your ongoing work to improve maternal and infant outcomes throughout the world. So we hope you all have a wonderful rest of your week, and we look forward to hearing from you, from those of you tuning in from India and elsewhere. If you would like to share information or anything that you are doing, please contact us, MIHCANcares@gmail.com.